Thank you, Chairman. Hello, everyone. My name is Daisuke Togawa from Hamamatsu University. Thank you for staying in the last talk. This is my disclosure. I'm going to talk about the disabled activity after the adult spinal deformity surgery. So corrective fusion surgery for the adult spinal deformity often requires long spinal fusion. Even in this the successful corrective cases, the correction looks good, but this long fusion may negatively impact on bending forward activities due to back stiffness after the surgery. So the purpose of this study is to investigate whether the adult spinal deformity patients experience difficulties in daily activities after corrective fusion surgery, especially on bending forward actions. 101 consecutive cases, adult spinal deformity cases with the corrective surgery from thoracic to pelvis, average age was 69. The same study was conducted to the volunteers with age over 50, 328 cases. Average age was 74. This is our original disabled activity questionnaires containing the 7 daily actions, including bending forward motion, gait, nail cut, laying in supine position, wipe bottoms, wear pants, pick up objects from floor, and get down on all fours. These were evaluated by numerical rating scale from 1, very easy, to 10, very difficult. Radiographic parameters were measured by software in standing total spine and pelvic X-rays. And the sagittal modifiers, the changing of the sagittal modifiers were evaluated by SRS 12 classifications. As a QOL questionnaires, Osprey Disability Index, SRS 22, and satisfaction score for surgical treatments are evaluated in all patients. Results. The pre-op status of the adult spinal deformity patients shows worse results in the disability questionnaires compared to the control group in every 7 actions. The radiographic parameters shows the good corrective fusion were achieved. PI-11 decreased to 8.6 degrees, and the sagittal vertical axis was improved from 122 to 43. And the pelvic tilt was 35 to 23. So correction is good. The health-related QOL is ODI is decreased to 33 in 1 year, and the SRS 22 were improved towards 1 year. So clinically successful cases are successful. The satisfaction score for the surgical treatment was average 82.4 at discharge, and was 71.2 at 6 months, and 70.4 at 1 year. So these patients are radiographically corrected, and QOL is good and satisfied with it. But when look at the disabled activity score, the nail cut and wipe bottoms, wear pants, pick up things from floors, and get down on all four more difficult compared to the pre-op, but decreased to towards the 1 year, so improved to the 1 year. This is the 69-year-old female with degenerative kyphoscoliosis. We performed multiple pontiostenotomy and rod rotation technique to fuse from T10 to iliac. The correction radiographic parameters are all good, and ODI was improved from 72 to 32 in 1 year. Even in these clinically successful cases, the disability index shows the nail cut, supine, laying supine, wipe bottoms, wear pants, pick up things from floors were more difficult compared to the pre-op status. Discussion. Scriber reported the impaired perineal care after the upper thoracic to iliac fusion in the adult spinal deformity cases. The present study showed the patient experienced difficulties on bending actions. However, it is still unknown the difficulties associated with the fusion lengths with or without pelvic fixation, how much and how long the improvement goes on. We have separate 13 small group cases with the long fusion from thoracic, but the distal instrumented vertebra L3, L4, and L5 and S. And the correction looks okay, but the improvement looks not smooth by time. From 6 months to 1 year, some of the actions were more difficult, and the corrections were not good enough in 1 year, even if the disability index looks similar to the iliac fixation group. So there is no, it seems that no advantage to stop L5 or S in this elderly population. This is the 2-year results of our results, disability index, but this is the only 68% of the follow-up. The improvement is still going on towards to the 2 years, but not reached to the pre-op status yet. So we have to wait to the 100% follow-up rate, follow-up study. So in conclusion, post-operative ASD patients have experienced difficulties on bending forward actions that need to be informed pre-operatively. And improvements have been observed towards post-operative 1 year, and further observations are still necessary to confirm the final improvement on these bending activities in this long corrective fusion studies. Thank you for your attention.
Great, thank you. Again, if there are any questions, please make your way to the microphone. I guess I'll start with the first speaker, Dr. Imaju. You seem to imply that the etiology of C5 palsy is very mechanical, going into kyphosis, collapse with foraminal narrowing. So I guess my question to you is, can we overcome this by better lordosis, maybe better distraction during the surgery? Distract the foramen?
Thank you. Graft bone is large, size is large, impact. The result of the large bone graft is the height of foramen is large.
So you recommend a bigger graft?
1 millimeter or 2 millimeter large.
Okay.
But collapse.
Okay. Yes. Please.
I'm Yu Yamato from Hamamatsu University. I have one question to Dr. Hayashi. You mentioned about the effect of osteoporotic vertebral fractures, and the osteoporotic vertebral fractures is the main reason of sagittal malalignment. So how about the effect of sagittal malalignment, the results of surgical treatment?
I did not investigate, but in my impression, this study included the mean fusion level was 1.3 in each group. So, and we excluded for the corrective fusion for the DLS. So I think in this study, it is the effect of SVA malalignment is little.
Thank you.
Dr. Nakai, you threw a lot of data up there, but you're saying, is there anything we can do? One of your conclusions in the abstract was focus on walking. Is that preoperatively, postoperatively?
Not about operation, but volunteer people.
Okay. And I guess, Dr. Togawa, I think your findings are fascinating because we always tell people hopefully they will be better after surgery. You're showing that there are many things they will not be better at, even if you have a good radiographic result. So I guess I'd ask you, how do you now counsel your patients? I think you probably do. And how are they receptive to that?
The expectation of the patients are quite different. So my point is that our clinical result is pretty good, but some of the patients didn't expect they couldn't put the socks by ourselves. So we have to tell them beforehand. In some patients couldn't wear the pants, for example, but postoperatively. But the clinical results are good. So, we have to tell them before. Some of the actions are very difficult, especially for bending actions.
Question?
I'm Dr. Yashi from Tokyo. I have a question to Dr. Togawa. Your disability score is really interesting. Thank you very much for that. And let me ask you about did you check or find any relationship between the length of fusion and the disability score? You may go to the upper thoracic or stop at the lower thoracic. So did you check that?
Thank you for your comment. The upper instrumented vertebra T6 or above tends to have the more difficulties, but it didn't reach to the statistically significant. So most of the patients are T9, T10 is the UIB, but the upper thoracic levels tends to have more difficulties.
So then, is that result affecting your decision to?
No.
No, okay.
No, because our important point is correction, because we are treating the deformity, and we are try to get the higher ODI, higher SRS-22, but some of the actions are very difficult. So what we try to do now is more extension to the rehab of the hip joint or shoulder girdle to be more flexible, because most of these are elderly people. So the hip motion is good, and they can put the socks. So the rehab is very important for them.
I see. Thank you.
Okay, with that,